This is what the word endemic looks like on a chart. The number of people infected with COVID-19 more or less stabilises over time, instead of showing big, unexpected surges like we're seeing now. So theoretically, a disease becomes endemic when its reproduction number, or R number, averages 1 over time. That means one infected person on average infects one other person, so the overall case burden doesn't go up or down. But it's not just about that R number. COVID-19 will become endemic when it's no longer an active crisis. That means that the level of severe disease and disruption to our lives falls down to an acceptable level. So who gets to decide what that is? It's a bit ironic that the word endemic begins with the word end, because that's not what it means at all. It actually signals the beginning of a new phase. Endemic, or endemos, means in the people. In other words, it's here to stay.
Endemic is one of those words that seems to be interpreted in different ways by different people, but the way I think about it is it's us moving from treating the disease as if it's a public health emergency to treating it like a disease that we're going to live with.
In the past century, humanity has survived a lot of diseases. The only disease affecting humans that's been completely eradicated has been smallpox. The last natural infection was in 1977 in Somalia. Then the disease was declared eradicated by the World Health Organization in 1980, almost 2 centuries after the invention of the smallpox vaccine by Edward Jenner. Before that though, it wreaked havoc. In the 20th century alone, it's estimated 300 million people died of smallpox. But it existed long before then. Scientists estimate it could have emerged anywhere between 16,000 and 68,000 years ago. The first known victim was an Egyptian pharaoh, Ramses V, who had small markings on his cheek preserved because of mummification. But we need to be careful about drawing comparisons between how smallpox ended and what the future of COVID-19 holds for us.
Recognising the only virus so far that's been eradicated is smallpox. And we haven't even been able to eradicate polio. Polio is a far simpler virus and still we can't eradicate it. So I would say that it would require a massive global effort and it would be near on impossible with COVID.
Most diseases throughout history have never really gone away. The pathogens just retreat to the animal host or mutate at low levels. The plague, for example, the one that wiped out about 50 million people in medieval times, still infects up to 2,000 people every year today. That's because it lives on in fleas in some parts of the world. There's no clear-cut way to say when a disease is endemic. The infection rates can be high and so can the deaths.
It's not going to be one day where we go, the pandemic is over. What we're going to see is the threat the virus poses to us slowly come down. I mean, there is a decision that we have to make, and it's a bit of an uncomfortable one that everyone avoids. How much disease are we going to be happy to live with in the community while we go about living our lives normally?
The virus behind the Spanish flu that also killed at least 50 million people eventually morphed into less lethal variants. Its descendants are part of the recurring strains of the flu that do the rounds each year, making it an endemic disease. There was no clear end to the 1918 outbreak, but after World War I, people were just keen to move on, even though the virus was still spreading in some form.
Flu, which we know is circulating endemically, it is there in our population all the time, but we have seasonal peaks. We have a peak in winter, for instance, with the increased transmission of flu. So that's the trajectory that we're hoping for with SARS-CoV-2.
In addition to influenza, other endemic diseases like malaria, which infects 240 million people a year, HIV with 1.5 million new infections a year, and measles, which infects 10 million, still kill a significant number of people.
With flu kills hundreds of thousands of people each year. We make the decision that, well, we can live with that. We would rather people didn't get the flu and we have vaccines and we have treatments.
SARS ended with aggressive quarantine measures and social controls. The outbreaks were limited to a few places, such as Hong Kong and Toronto. But that level of containment was possible because the time between infection and sickness, that is the incubation period, was very short. It took 2 to 7 days after infection to show symptoms of SARS. COVID-19 takes an average of 5 to 6 days. The key difference, though, is that people who had SARS were not infectious before symptoms started to show, but people with COVID-19 are. Containment worked so well that there were only 8,000 SARS cases globally and just under 800 deaths. The last case was in 2004. But the World Health Organization technically hasn't declared it eradicated because the disease is zoonotic, meaning the pathogen lives on in animals.
Viruses are very complicated, and we saw from SARS-CoV-2, this is a zoonotic virus. This has an animal host, and it caused such mass morbidity and mortality in humans because it jumped a host, and we were a naive population with no previous exposure and no immunity. So this is why in that jump, it was quite deadly and continues to be quite deadly.
Compared to other diseases we've faced, COVID-19 has an upper hand. Unlike SARS, it can spread by people who don't know they have it. It's different to smallpox because it can jump species. It's less contagious than swine flu, and it's less deadly than Ebola, meaning it infects a lot of people but won't run out of victims. Experts say what happens from here with SARS-CoV-2 depends on 3 major factors: how long we can stay immune to it, how quickly the virus evolves, and how well we can treat it.
Every human is different, so the immunity of one might not be the same as the immunity of another, even if they both individuals got the same vaccine.
Our immune systems can offer varying levels of protection from all sorts of pathogens, so they can stop severe illness even though they won't necessarily stop infection or transmission. A good example of this is the common cold. It's caused by 4 endemic coronaviruses. Humans are first exposed to all 4 at a very young age, usually between 3 and 5 years old. Some young children get as many as 8 to 10 colds each year before they turn 2 years old, but fewer as they get older and develop immunity to the viruses.
Absolutely, that could be how things go. But we've got to realise that, we have 4 coronavirus that cause the common cold type symptom. We also have over 100 rhinoviruses that do the same thing. So the common cold is common in symptoms, but very complicated in what virus is actually causing it.
These seasonal coronaviruses might give us a roadmap to how SARS-CoV-2 might evolve, but little is known about how they continue to thrive. One of the best studied examples, a seasonal coronavirus called 229E, infects people repeatedly throughout their lives. What's not clear is whether these reinfections were the result of fading immunity or whether the virus was changing itself to dodge immunity. Scientists collected some decades-old blood samples of people who were probably exposed to 229E and tested them for antibodies. The results were striking. Blood samples from the 1980s contained high levels of infection-blocking antibodies against a 1984 version of 229E, but they had much less capacity to neutralise a 1990s version of the virus, and even less against variants from the 2000s and 2010s. So people had immunity to the virus from the recent past, but not to the versions that were yet to come, suggesting that the virus was evolving to evade immunity. There are some clear parallels here. Variants such as Omicron and Delta carry mutations that dodge antibodies generated by past versions of SARS-CoV-2. How SARS-CoV-2 evolves over the coming years and months will determine how this crisis ends. If it behaves like other coronaviruses, it could become just a mild nuisance in years or decades from now. But it could also evolve to become much more life-threatening.
If a virus becomes less virulent, it has a selective advantage, because if it doesn't kill the person that it infects, that person has more of an opportunity to spread the virus. That's actually not the case with the SARS-CoV-2 virus, because severe disease happens so late, the infectiousness period has already sort of been and gone. So this is the one thing that we're not confident about, what that next variant will look like in terms of severity, because there really isn't a selective pressure that is favouring a less virulent virus.
But the research isn't clear yet on where Omicron came from, so it's just too early to say whether it's on its way to becoming a mild nuisance. The science journal Nature mapped the mutations of the variants we've seen so far. Omicron has the most mutations, and there's no clear link between it and its predecessors, Alpha, Beta, and Delta. Virologists estimate Omicron emerged from a genetic ancestor from more than a year ago.
If there's one thing the last 2 years has taught all of us, is that don't ever get cocky and think that you can predict what's going to happen next.
What's going to be important is how much older people and the vulnerable are able to acquire immunity.
We need to work hard to protect those vulnerable people, just like we work hard to protect vulnerable people during the influenza.
After a person is exposed to a virus, the immune system retains a memory of it. There are the antibodies that circulate in the blood and recognise the viruses and neutralise them. Helper T cells help to recognise the pathogens, killer T cells kill pathogens, and B cells make new antibodies when the body needs them. People who recover from COVID-19 have all 4 of these types of cells, but there's also evidence that immunity wanes over time by as much as half every 3 months. And then there's the question of new variants.
In some circumstances, we're seeing immunity only lasting weeks for Omicron, but for others, it could be months. Every human is different. So the immunity of one might not be the same as the immunity of another, even if they both individuals got the same vaccine.
When vaccines first came out, there was a huge sense of relief, and many people felt it marked the beginning of the end of the pandemic. But Omicron has shown us how a new variant can evade immunity.
We have new strains of SARS-CoV-2 that are circulating, and the protection that the vaccine provided against Delta is a little higher than the protection that these vaccines are providing against Omicron.
The good news is that now we have them, vaccines can be updated pretty quickly, as fast as 6 weeks for the mRNA ones, but that doesn't account for the regulatory approval times.
We certainly had a focus on vaccines, and rightly so, but I think in this next year, we'll see a lot more discussion around treatments.
Treatments might make endemic status come around faster. Right now, most of them can only be given in hospital.
Getting treatments that are able to prevent people from dying and are sort of easy to take and don't require you to go to hospital have an important role to play in the way we're going to live with the virus over the next while.
Finding an effective oral treatment would be a high priority because it would make it more accessible, and that would be a game changer for people living in remote areas or in countries with basic hospital systems. The 2 new contenders are Pfizer's drug Paxlovid, which reduces the risk of severe illness by 89% within 3 days after symptoms begin, and Merck's Molnupiravir, which cut the risk of hospitalizations and death by 30%. Both Molnupiravir and Paxlovid have been granted provisional approval in Australia, the first oral treatments for COVID-19 to be granted that status.
I think another really interesting example is to think about HIV/AIDS. So the threat that HIV/AIDS posed to the community was transformed when we developed medicines that were able to really change that disease from a life sentence or a death sentence to a chronic, manageable disease.
Omicron does seem to be less severe than previous variants. In animal studies, Omicron was less effective than Delta at infecting lung tissue, which makes severe pneumonia less likely. Early data is showing that 0.5% of Omicron cases end up in hospital, compared to 1.3% of Delta cases.
At the moment, Omicron, allegedly is less virulent but more transmissible. So that means it's going to spread faster, but theoretically cause less severe disease.
But achieving widespread immunity through natural infection has a huge cost. There were more than 1,300 deaths recorded in Australia between July and the end of December last year. That was from just under 400,000 cases. With Omicron as the dominant variant, there have been more than 2,300 deaths from more than 2.5 million recorded cases. We wouldn't call COVID-19 endemic just yet because it still puts an enormous stress on our systems. Ultimately, we're in a much better position than we were towards the start of the pandemic. There are literally thousands upon thousands upon thousands of studies on how COVID-19 works. We have vaccines, rapid tests, boosters, treatments, bringing the endemic label closer than ever. But as other diseases have shown, there's one key factor in deciding when a pandemic ends. It's people. People decide when a pandemic ends. So there are some big questions we need to ask ourselves. How much disruption can we put up with? How much death is okay? How much infection can we expect? And most of all, are we prepared for the next one?